Welcome back, everyone. It's my pleasure and my honor to welcome Dr. Robert Groves, who's Executive Vice President and Chief Medical Officer of the Banner Aetna joint venture. Dr. Groves, it's so great to have you with us today.
It is great to be here, Mark. Thanks for inviting me. I'm looking forward to the conversation.
Absolutely. Well, you and your colleagues are doing really amazing things there. But let's begin, because I think a lot of people in the audience might not be familiar. Tell us about Banner Aetna. Just explain what the joint venture is, how it came together, and your specific role inside it.
Sure. Yeah. Banner Health is about a $10 billion integrated delivery system that's based in Phoenix, Arizona. And we actually have a pretty long history of working specifically with Aetna on an ACO model that predates the joint venture by several years. And what we found in that relationship is that we were fairly well aligned as partners in value-based care, that we worked well together. We were able to show significant savings in the operations of the ACO. And about 4 or 5 years ago, Banner started thinking more seriously about insurance offerings. And the decision for Banner at the time was build or partner, right? If you go back far enough in Banner's history, they did have an insurance product at one time when it was Good Samaritan, but that goes way back to 2000. And then they decided to focus for a time. But when the issue came up, the successful partnership between Banner and Aetna was a key driving influence for forming that relationship. There was also there were some statements by Mark Bertolini, who at the time was CEO of Aetna, about pushing functions that are really care functions from insurance to the delivery side. And for those of you who are not familiar with how that historically has worked, for the most part, hospitals were concerned about case management and managing patients, navigating the system only from the time of admission to the time of discharge. And in a fee-for-service world, that makes perfect sense. That's the incentive that drove the behavior. If you look at total cost of care, it was the payers who actually put programs in place to help manage those patients outside of those 4 hospital walls. And so payers typically had fairly well developed case management programs for outpatients, and hospitals focused on managing those inpatients, getting them in and out as safely and as quickly as possible. But Bertolini was bringing up something new. He said, why, now that we're completely at risk together for this, why not push those functions over to the delivery side? And at first glance, as my boss likes to say, you wonder if the fox is watching the hen house. But remember, 50% ownership changes the incentive structure. Banner has a vested interest in not only providing high quality, but being maximally efficient in this space. And so the company was formed for a variety of reasons. One was, this is Banner's play in the commercial insurance space. This is Banner's product, half owned, if you will. The second is Banner has become quite large as an organization. And of course, Aetna CVS is very large as an organization. It's more difficult in a lot of circumstances for those large organizations to be agile, take advantage of new developments, innovate, if you will, although that phrase may be tired, it still has meaning. And so the joint venture was formed as a way to really accelerate the transformation of care, specifically in Arizona. But if you look at the way the joint venture is structured, we have folks all over the country. If a business is headquartered in Arizona, then they are potentially eligible for Banner Aetna coverage, and all of their employees, whether in Arizona or not, are eligible for that coverage as well.
Yeah. And I know it's not an indication of how big this joint venture is, but just for point of reference, how many people are on staff at Banner Aetna?
That's a great question, and one that is a bit nuanced. And first of all, our covered lives currently are about 350,000. So
Okay,
not tiny, but not massive either. Substantial in Arizona for sure.
yeah.
And I'm sorry, I forgot the second part of your question, Mark.
Well, I just wanted to know the number of staff, even though I think that
yes. Yeah, that's a
right, the
great
covered
question.
lives is more important and more significant. But
Well,
yeah.
so the way that this works is we have a very small staff that is officially employed by Banner Aetna proper, which, by the way, is an independently licensed insurance company in the state of Arizona. So our license is independent from Aetna. We are a payer, not a provider. And so what we do is we borrow services from Banner and we borrow services from Aetna. Aetna being the experts on plan administration, Banner being the experts on delivery. And as part of that process, as I mentioned earlier, we have seen progressively pushing decision-making around certain aspects of the business over to the Banner Insurance Division. And what am I talking about? I'm thinking prior authorization, as well as concurrent review. There are pharmacy functions. Banner has its own pharmacy service. And so there are pharmacy functions that are being pushed over to the Banner side instead of traditionally where that's managed on the insurance side. So the short answer to your question is we employ the C-suite. Everything else is borrowed services from Banner or Aetna.
Okay, that makes sense. Thank you for explaining that. I'm sure people were just kind of curious how it works. So tell me, let's get to the meat of all of this. You and your colleagues are involved in some really interesting initiatives that you had shared with me, including your EICU development, as well as others. And let's start wherever you would like, Dr. Groves, but tell us exactly how you're implementing this broad strategy, which you articulated so well to me just a moment ago. Give us a couple of examples of how you're moving forward.
Sure. Let me clarify on the EICU issue. First of all, the EICU predates the joint venture. I would actually, that was my introduction to leadership in the Banner system.
I see. Okay.
I was hired back in 2005 to roll out the EICU. For those of you who aren't familiar with it, the concept is there are cameras and microphones, so that there's two-way audio, video communication with every ICU bed, with a central core of off-site professionals that include intensivists and nurse experts. And there's also a set of computer algorithms that are constantly trolling, if you will, the information that's coming out of those ICUs and helping to identify patients who may be at risk. And that process then focuses the attention of the intensivist team in that core, if you will, on those patients who might need a little bit of extra help. And it was rolled out as an addition to bedside staffing, not a replacement for bedside staffing. We have been highly successful in that area. I've not had direct hands-on oversight of that for some time, but I can tell you that we were very glad to have it, particularly in the face of a pandemic, when getting out and in of an ICU room could take a whole lot of time. Being able to have a direct conversation, being able to assess monitors, et cetera, from outside the room becomes critical in situations like that. But it was an advantage before that even happened. So I think that was part of the reason that Aetna was interested in partnering with us, is that we were doing innovative things like that. But that predated the joint venture. To get to what the joint venture has done and is doing, first of all, we can say that we have the best prices in the market because we get that relationship with Banner right. There are discounts on services. And the second thing that's different is we're really focused on the customer experience. Now, for anybody who has been in healthcare for a while, you know that nothing in healthcare seems to happen overnight. It always takes longer than we want, but we have seen steady progress in that regard. For example, We have a portal that is a Banner Aetna portal that is increasingly facile at moving from insurance issues, what's my coverage, what services are available to me, and what's my EMR, what records does my physician have, and so forth. So toggling between those two, we're working on single sign-on now, so that you have one place that you can go and get all the information you need from both sides of the equation. And that is a very functional portal even now. I think it's among the best in the industry in terms of providing that service and that ease of use. From a clinical standpoint, we were the first to introduce, for example, text-based telemedicine, for lack of a better term. I have some thoughts on that term in general, but text-based remote care with a company called 98.6. Now, the question often comes up in these relationships, well, shouldn't Banner just provide all the telehealth services? And if you think about the delivery system and all the priorities that they have to address, I think that will come, that one day it will be seamless in terms of I can see my physician, and the pandemic accelerated this immensely, seamless as to when I can see my physician remotely, when I don't need to come in, on site if I prefer, or I need to come in. And I think we're getting there. But this service was taking what had historically been an old-fashioned model of telemedicine. And I call it that because the old-fashioned model was I set up an appointment time, I try to coordinate the schedules of the doctor and the patient so that they can both be in the same place at the same time for an appointment. Well, this model said, you know what, how about if it's on demand, so that anytime I can open up an app and I can text the care team at 98.6, get a response, and get most of the information done and most of what I need done without ever having to coordinate schedules and have that online appointment. Now in Arizona, a single video appointment is required to establish the relationship, the patient relationship. That's not a problem. 98.6 is perfectly capable of providing that video service, but it's really amazing how much can be accomplished with text only. So we were the first insurer to contract with 98.6 when they came out of hibernation, if you will, a few years ago. Other services that we're looking at, we are engaged with a couple of partners in looking at prior authorization, which nobody likes. I can guarantee you that physicians don't like prior authorization. They don't like the mother may I feel that it has. Certainly, we don't like prior authorization because it's time consuming, labor intensive, and it's contentious. It creates that adversarial feel to the whole situation. I see this as a problem primarily of knowledge management. And so we're trying to leverage AI and machine learning, as well as the association or the interpretation of free text by computers, which is getting better and better, to actually look at the medical record prior to the appointment and understand, based on plan, what is required for a specific service. And that changes the dynamic. Now, we're not there yet, but we are very confident that we'll be able to come up with strategies that really start to streamline the way prior authorization looks and feels, both to the patient and the physician. The ideal state is, if I'm a physician and I have a patient across from me and I want a CT scan, that right there in front of me, I have all the information I need to determine if I've checked all the boxes, if you will, and can go ahead and order it, or if there's something that still needs to be done before I can get that scan done. That changes the dynamic between the patient and the physician. I don't want to underplay this, because once I commit, I need a CT scan. If it feels like the insurance company is second guessing me, that damages the relationship between patient and physician to some extent. And often the physician feels like the only choice they have is to say, those darn insurance companies always second guessing what I do, I'm the doctor, et cetera. However, if there is knowledge management, so as a physician, I can not only see what's required, but there are links there to the literature so I can see why it's required. then it's a very different conversation with the patient, and there's very little risk of damaging that relationship in that setting. And if all the boxes are checked, then it's an instant approval. You get your number and you can show up for your exam confident that it's going to be done.
Okay, so two questions. One, do you, I want to phrase this in just the right way so that I don't feel like I'm making your life difficult. In moving forward on that goal, has there been any internal resistance from Aetna? Well, I'll ask that and then another follow-up.
There has certainly been some resistance, but it is, it's navigating these issues is not necessarily because, Aetna is against us or the entity to whom we outsource this current relationship is against us. There are hoops that have to be jumped through. Standardization is a very important concept in business, right? And so Aetna's interest is in doing things the same way to the extent possible, and healthcare is local, there have to be exceptions, but doing things the same way as much as possible across their whole book of business. It's reliability theory, right? To the extent that you can do that, you're far more likely to have a reliable program, a reliable service, because there's one way to do it. It's kind of like the old Southwest. We only fly 737s because the pilots get to know them very well. They can shift routes easily, as opposed to another airline that has multiple airplanes. So it's that concept. And that does need to be addressed. And the benefit of a new strategy, we need to be able to convince our partners that that exceeds the pain, if you will, of the change that we're recommending. And so it is a notoriously difficult thing to do between two large organizations. But I think we've done fairly well at making our case. And there is no pushback against the fact that prior authorization is a major dissatisfier to both patients and physicians. So it's something that's worth the battle, if you will.
Yeah. And when will you be kind of like live with the streamlined version of it?
Yeah, we are still on track for this year. If I were to guess right, and by the way, there are still some barriers that we need to get past in terms of relationships among external vendors, not so much internal Aetna in this case, but external vendors that hold the contract now and are not necessarily as motivated as we are to change that relationship or to adjust that relationship. But we fully anticipate that we'll be able to begin the process, start that streamlining this year. So it's not something that's 5 years in the offing. It's something we hope to accomplish in short order. And by the way, that the track that we're on now that we think is the ideal option is not the only track. And we'll have to start in some place that's manageable so that we can understand the process better. Starting in, for example, high-tech imaging makes the most sense as an initial pilot of this idea and this strategy. And that's where we'll start.
Absolutely. And okay, so now because I'm a journalist, I have to ask you, what have been the most challenging, and it can be along any dimension, what have been the biggest challenges so far in this joint venture? And it can be culture, which could be a very promising area to discuss. It could be technological, it could be anything. What have been so far the biggest challenges, and how are you overcoming?
Yeah, I think that in any joint venture, one of the biggest challenges that one will face is alignment of the parent companies and creating that win-win that allows both to see the wisdom of a particular strategy or a particular move, particularly when that move may be perceived as disruptive to current relationships or current practice. Healthcare is notoriously cautious in moving forward with significant change. There's a reason for that. The stakes are pretty high. when you're talking about patients' lives. And so there is a reason for that, but it does make it challenging to move forward. And I think that the biggest issue really is alignment. I think culturally, there are some barriers to overcome. Historically, the relationship between payer and provider has been adversarial, for lack of a better term, and because I think that accurately describes the relationship. I mean, historically, when you're trying to negotiate rates, the insurance payer is trying to get rates down as low as possible. And of course, on the other side, they want their rates as high as reasonably possible so that they can meet their bottom line. And so taking that and turning it on its head a little bit and saying, look, if we do this right, we both benefit because you get to reap the benefits of a successful efficiency management program, just like we do. That changes the equation significantly, and that allows the opportunity for alignment. But as an example of where that can get challenging is, as you know, Aetna, and this was soon after I took on the role of EVP and CMO with Banner Aetna approximately 4 years ago. Soon after that, of course, CVS bought Aetna. And that changed the dynamic again, because CVS has a very important interest in developing their health hub strategy, expanding services that are available in their minute clinics, things like nutrition programs and on-site care, urgent type care, if you will, although it's retail technically. Those sorts of issues became paramount for CVS and weren't necessarily paramount for Banner Health. As you can see, that could be perceived as competitive to the urgent care centers owned by Banner Health. The way that we navigated that space, though, was to say, look, this is coming, whether it's through Walmart, Village MD, Walgreens, CVS, Amazon. This is coming. Doesn't it make sense to partner with an organization who has a vested interest in your success rather than going head to head with an organization that does not? And so we were able to navigate that space by aligning, once again, the incentives so that the case that we made is, look, we want our members to be able to get what they want, where and when they want it, meeting customers where they are. You've heard all of the lingo around the customer experience. Well, because of the footprint of CVS, and because of the services that they're contemplating and implementing around telehealth and around nutrition services, addressing metabolic syndrome, that all made sense for our patients. And all we had to do then was say, look, these folks are going to be going somewhere. Psychographic profiles tell us that there are significant portions of a population in our market that are going to preferentially prioritize convenience and cost over everything else. There are other psychographics who may not, but there's a substantial portion of the population that that's what they're looking for. And so if that's what they're looking for and they need additional services, doesn't it make sense to have them visit a partner who is going to help us keep folks in the system rather than a partner who has no interest at all in doing so?
Yeah, absolutely. I do just have to say, Dr. Groves, I think you would do very well as an ambassador to the UN.
Well, thank you very much, Mark. I'll take that as a compliment.
That can be your fourth career. But and absolutely you should take it as a compliment. How are the clinicians? I mean, I have been in healthcare publishing for 32 years, and I've been reporting on especially the physician culture for that entire time. And as you know, a lot has changed. But physicians are so amazing because they're tremendously intelligent, focused, skilled, knowledgeable, dedicated people. But, so you knew there was a but in this sense, that they've historically been rather hostile to change. Now, I know that is changing in the healthcare system right now, but if you look at the docs who started in private practice 30 years ago, and granted, some of them are cruising towards retirement at some point, some of them, not all, but some are very hostile to everything, like everything we've been talking about. They're like, oh, over my dead body, blah, 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 blah. The younger docs, much less so, or those in a shorter term in practice.
True.
How have you been able to move the physician culture through leadership?
Yeah, well, first of all, I have to give credit to my co-conspirator, if you will, the chief medical officer for the Banner Insurance Division. We work very closely to look at what concerns physicians today and what can we do. That's another alignment issue, right? I mean, how is it in their best interest for us to be successful? Certainly, incentives matter a lot. So at the same time that we are looking to innovate and bring in new strategies and practices, we're also working with my colleague, Ed Clark at Banner Health, looking to incentivize appropriately physicians to participate. So they get to share in those cost savings as part of that. Of course, there are quality requirements that keep that very balanced, unlike the failure of HMOs, for example, was mostly about our inability to use data to ensure that people weren't just cutting corners and not providing care that was needed. I think those days are behind us. But yes, incentives matter a lot to physicians. And a parallel focus is how can we make it easier for physicians to do business with us as a payer? Prior auth is part of that equation. For example, we have something that's called the Multi-Disciplinary Care Team, which is just like it sounds. Initially, that was housed on the Aetna side of the house, if you will, staffed and managed there. But this year, we moved that over to Banner. And so the advantage of that is that staff is the same staff that the employed physicians work with. And so there's access to the EMR directly. There's knowledge of who the physicians are in the Valley, what they do, what they can be depended on for, et cetera. And so that direct relationship goes a long way. Similarly, if utilization review is being done by a Banner physician, that's a different feel than if it's being done by the payer. And we've made some big shifts there and have found that it works very, very well when the incentives are aligned. So, I have some personal experience in this and rolling out the EICU. If you go back to 2005, it was a very different environment. And many of those doctors were experiencing firsthand that transition. And I can tell you, and you wouldn't be surprised, that many of those physicians did not want a camera looking over their shoulder, did not want somebody else involved in the care of their patients. We had folks hanging towels over the camera, threatening to report me to the state medical board for this craziness. And what we did was very slowly and methodically over time identify the advantages and for the physicians, for the practicing physicians. We said, look, we're not trying to replace you. What I want every day is an awake, alert intensivist who is there to recognize complex patterns, create a relationship with the family. And I want you to be able to be alert and awake and on your game to do that tomorrow too. So let us take care of the rote stuff that computers are good at. Let the computers recognize adverse trends, and we will make it easier for you to do your job. You'll be better rested and you'll perform better as a result. And over time, that works.
Yeah, they had to see that it was going to help them and not hurt them.
Yes, exactly so.
So speaking of helping and not hurting, let's talk about data analytics. One of the things that, everyone I talk to in US healthcare agrees on one thing, which is amazing, right? That there could be one thing that everyone agrees on.
It is.
And that is, we will live or die by data, right? And by analytics. And one of the key things in moving, every smart organization I talk to, they're using clinical performance dashboards with their physicians, and they're using them smartly. They're using them wisely, right? Not punitively, not gotcha-ly, but rather let's, sit down with you. And so if there's a a group practice of 10 cardiologists that's embedded in your larger group, and you look at the performance, and Dr. X is like way over here in the corner, in terms of both outcomes and costs, and all the other docs are way over here in a corner, it's time to look at the data and then talk to Dr. X, right? Similarly, the more information that you can give to physicians at the point of clinical decision making and ordering and care delivery, the more powerful they can become in really changing the trajectories of their patients' health. So how would you frame what you're doing with data analytics, especially in terms of clinical transformation, especially in terms of care management and population health management? Because that seems to be the most fruitful ground possible in this kind of joint venture, right?
Yeah, that's absolutely true. And one of the projects that we initially undertook early on in this joint venture, because of the very reasons that you delineated so nicely there, is, how are we going to align incentives? And in order to do that, we need performance information on physicians. I've always been of the opinion, it hasn't changed, that if we do a good job of putting information in front of physicians, they will manage themselves. I mean, if you showed me when I was actively practicing that somebody down the street had better outcomes than me at a lower cost, the very first thing I'm going to say is, what's he doing? Because I want to do it too. I'm not, we're competitive. We're not used to being second rate. We don't want to be second rate.
Yeah, that's one of the things that I hear every time when you show the doctors their data compare them to others. They do not want to be, like I say, there are 9 docs who are doing great, and then Dr. X is not doing so great. That's the greatest motivator to move Dr. X, right?
Absolutely. And then when you add to that the power of financial incentives, which whether you like it or not, they work, then it becomes paramount. And even the other members of the group are going to say, wow, Dr. X is holding us back. We're not getting the full benefit of our excellent care because he's not on board. They will put pressure on that doc to come up to speed and perform at the level of the rest of the group. So that, to me, is one of the keys to advancing the notion of value-based care, is getting the right information. And by the way, we talk about, when I think about this problem, I think about it as a knowledge management problem. Yeah. In 1950, it took 50 years for information to double. Yeah. Now it is measured in weeks. So there is no way that any one person can manage all of that information and keep up to date on everything all the time. We have to have systems, and they have to today be empowered by artificial intelligence if we're ever going to keep up with the information that's out there.
Yeah, I'm sure you've heard their little data analyses that, like, if you're a practicing physician, to even keep up on the clinical literature, you'd have to be reading 24/7. Like, you couldn't be eating, sleeping, or anything. Exactly. So exactly. Now, in terms of the marrying clinical and claims data, the phrase that is constantly used, I feel like I'm at a perpetual healthcare wedding, right? We're going to marry clinical claims, right?
They've been engaged for a long time. But
right, exactly. How has that been going? Because that, again, to me, that seems like an absolute sweet spot.
Yeah, and I agree with you. And it's been something that we wanted, but again, we've got to align both of our partners on the same strategy. Initially, when we started the joint venture, we had a well-known partner, and we attempted to move down this road. And frankly, we're not satisfied with the early performance. And so we pulled back. And at the same time that we were pulling back with that initial effort, Banner was entertaining their ability to do exactly the same thing, certainly for their Medicare population, certainly for their Medicaid population. They have successful programs in both areas. And it made sense to include commercial in that effort as well. And so we landed on a company that both could live with and thought would be a great partner to develop that database. And we are in mid-stride in actually making that happen so that we do have a comprehensive 360-degree view of each and every patient that includes claims and information about their clinical status as well. I think it's going to be very important for us to do that. I think it'll take a while to get the kinks worked out to marry those two systems in a single database with a single set of definitions, et cetera. But I do believe that the technology is advanced enough now that that is entirely possible. There are a number of companies who are looking at this, as I'm sure you're aware, and I think it's going to be critical to our success going forward. That project is well underway in mid-stride, and we believe that we're going to have significant and substantial results from that project in this calendar year as well.
Oh, that's wonderful. I have to say, Dr.
Well,
Rose,
let me
yeah,
rephrase
please.
that.
Yeah.
In the next calendar year.
Oh, okay, in 2022.
Yeah, it's a little bit late in the season to make that claim. So let me be clear about what I'm suggesting.
That's fine. Thank you for that clarification. I just have to say, Dr. Rose, I mean, that is such a hopeful note because it's kind of where everyone needs to go, right? And we constantly hear in all different situations and landscapes, if only we can marry clinical and claims data successfully, like everyone's trying, but if only we can do it successfully, if only we can do it smoothly and regularly and in a predictable way so that we're, right?
Yeah, and it's not to minimize the challenges, but because when you say it on the surface, it's like, well, everybody's on, Cerner in the case of Banner and Aetna, you only have one claim system. Why is that hard? Well, the reason it's hard is because of the way that insurance historically has worked in this country. And one cannot sell to many employers an insurance product that does not include a broad network option. Now, it might be more expensive, but it means that all comers are welcome. You add to that, and what that means is outside of our system, how do we capture that data and get it into the works? HIEs are one example of how that might happen. Farm lab data can be independent of that. So that's another way that might happen. So it's not as simple as, gee, marry these two systems. The other point worth making is that in order to have broad coverage, our performance network, maybe 20% now, maybe 25% of it is Banner employed physicians. The rest is a clinically integrated network of independent docs on different EMRs. And so you got to weave all of that together. It's no simple task.
Yeah, absolutely. We just have a little bit of time. I'd like to ask you, going back up to kind of the 40,000 feet level, what have been the biggest lessons learned so far? What learnings can you share with us on the journey of 1,000 miles so far?
Yeah, I think that probably the most important take-home point is that, first of all, our hearts have to be in the right place so that we can be proud when we go out and say we're really trying to improve care for patients. Docs care about that a lot. And not surprisingly, it's what they should care about. And so they have to feel that we really are on their team and the things that we're doing are in support of their efforts to optimally care for their patients. I think the lesson about change is that incentives drive behavior. I mean, one of the things that I've been trying to promote is that those of us who have latched on to the train of contempt that seems to be popular now in social media and with a variety of factors in our society. Step back for a minute and get to know the people that are in that evil insurance company. Are they really evil, or is it a system that has incentives that no longer serve us? I mean, we are all trying really hard to do the best we can under the system that we are currently in. And yes, we want to advocate to change that system. And I do think national policy, the federal government is responsible for more than half of healthcare payments now. So that has to be part of the equation. But my premise is that for the most part, we have really good ethical people in healthcare in every corner of the market, whether it's payers or, whatever you want to talk about. And by the way, we have equal challenges for not so great players in every corner of the market as well. But for the most part, it is really good people working hard to serve the companies for whom they work. And they are following the incentives that we have set up and said, here's what's important. If we want to change what they do every day, then we've got to change the incentive model to address what we believe to be important now in providing excellent care.
Yeah, absolutely. So last question, what I would love to have this conversation in a year and in 2 years and in 3 years. 2 years from now, what will this conversation look like? What will we be talking about?
Well, the first thing I'm going to do, Mark, is invoke the Yogi Berra rule. And he famously said, prediction is difficult, especially about the future.
Yeah.
And nowhere is that more true than in healthcare. The other thing that I'll say is it may have been Bill Gates that once said, we overestimate the pace at which change will occur routinely, but we underestimate the profundity of that change and the speed with which it happens when it really gets to that tipping point. I've been wrong about this before. I have thought we would be further along than we are now. And I've learned with years of experience what predictions like the one you're suggesting mean. Nobody could have predicted the pandemic. I think that's accelerated the process for us, if there's any silver lining in all the pain and suffering that's caused. And I don't want to minimize that pain and suffering, but it has accelerated the move to digitally enabled care for obvious reasons. I think if we look 2 to 5 years down the road, I've recently had a conversation with a colleague, Nathan Bays, who is an attorney that's been in the space for a long time and works with mergers and acquisitions and also advises the top delivery systems in the country. And what he said, I think, is right. He said, I think we're going to see some major trends. One is a move to home. And by the way, he says, follow the money. Who's investing in what in terms of capital markets, and you'll get a pretty good idea of what the trends are. So home-based care, I think, is going to be big, whether it's hospital at home or an enhanced level of service for home care in general, physical therapy at home enabled by technology. There are all kinds of moves afoot to take care from out of institutions into the home. The other piece of the puzzle that I think is reliable is that we're increasingly going to see social dollars come from healthcare. What do I mean by that? I mean, historically, we've relied on what is a pretty fragmented social safety net in this country to establish equity in access, and it has not been as successful as we need it to be. And so increasingly, you're seeing large delivery systems devote real dollars to social programs. And that can be anything from transportation to providing in-home services.
Well,
all
and
of the things
a couple of systems have actually built housing.
Absolutely, yeah. In New York, that is not uncommon for even hotel rooms to be purchased on behalf of patients because they need someplace to live so they don't freeze to death and bounce back to the hospital and suffer the consequences of exposure. But it is really expensive to keep somebody in a hospital to do that. So you're seeing all kinds of moves like that. It's an interesting debate because I think in my conversations with Brent James, they addressed that at Intermountain many years ago and said, well, our job is to reduce healthcare costs. We'll leave the social contract to government. But when it gets to the point where real dollars are at risk and real savings are possible by devoting more dollars to social determinants, that's what's going to happen. And that's what we see happening. And I expect that trend to continue. And then the third thing has to do with pharmacy. I think we're going to see a tighter relationship between pharmacy and delivery over time. in particular because of the biologics, very expensive drugs that require a lot of insight into specific patient parameters, might require close monitoring, follow-up, might need to be administered in an institutional setting because it's intravenous or they're, higher risk, et cetera. So that relationship is likely to get tighter over time. In those three trends, I think he's right about that, and I certainly want to give Nathan credit for enlightening me in that regard. I think the other trend that we're seeing is the trend in AI, machine learning, and certainly that's going to continue. I don't think there's any way to put that genie back in the bottle. I think we need to be very cautious because there are concerns about built-in bias that should not be ignored. And the physician's job has really changed from one of remembering everything that I need to do in this patient to understanding in this specific patient, where do the standard protocols not apply? So it's a very different role, and one that I think physicians are still learning how to do. We've all been chagrined to see the progress note that says, awake and alert comatose patient. Well, that is a perfect example of the function of, carry forward and not thinking about what I need to remove from the equation instead of what I need to add to the equation. So I think that we're in transition with regard to that skill.
Well, and I am definitely a glass half full person, and I sense that you are also, Doctor.
Yes, I am.
And one of the great glass half full elements in this is that I believe that AI and machine learning, we're very early on in our journey around those technologies and capabilities. I think amazingly good things will come out of harnessing them correctly. And I can see where an organization like yours could end up in the lead, among the truly pioneering organizations in this country to really use AI and machine learning in the best way because of your position. So hopefully when we speak again in 2 years, you'll have something to say about that.
Mark, we're on the same page. I am an optimist, and I do believe that there is enough pressure now and enough understanding of what the real challenges are that we are going to be able to move forward. I mean, it's always been difficult for many to understand how we can be described as the best healthcare system in the world and the worst in the same breath. And the reason is complex, and it has to do with our insurance, our payment system, the incentives, but it also has to do with the function for which we are optimized. And in this country, that's rescue, right? I mean, there is no place in the world that I would rather be if I were unfortunate enough to get hit by a truck. That there's no place that has a better chance of getting me through that and surviving in the best shape possible. We do rescue incredibly well.
Yeah.
What we haven't done is the day-to-day management and prevention of chronic disease. And that has everything to do with those social dollars, as well as our focus as a country on prevention and chronic disease. And I think what we're seeing is a shift. We don't want to lose our ability to rescue, but we need to put more focus on our ability to prevent.
Well, I think one of the great opportunities that you and your colleagues are exploiting right now is the opportunity to move upstream. Everyone knows that if we can move upstream, this is what I'm privileged to have traveled to Europe a number of times, but also professionally a few times, and to have met with healthcare leaders in a few different countries there. And because their systems are very different from ours, they're very focused on preventive and primary care.
Yes,
and
they are.
So I was at a hospital in Madrid in 2017, and the director of population health said, well, what you're calling population health in the US, we've been doing here for 30 years because we have to. We're underfunded compared to you. And so we have to.
And I want to highlight a couple of initiatives that we've been working on actually pre-pandemic. The question came up on what should we focus for the next, for the coming years in terms of disease management. Where is the where's the opportunity? And what we landed on was metabolic syndrome and all of its downstream consequences may be responsible for as much as half of the total chronic disease spend in this country. And that's something that we can get ahead of. We can identify those folks that have markers for metabolic syndrome and identify those folks that have pre-diabetes. And even those who are diabetics, we're now talking about putting them into remission, up to 60% of the time in peer-reviewed studies.
Yeah.
And that's just not something that was on the radar before,
Right.
but we're getting much more sophisticated. And so our focus on metabolic syndrome, diabetes, and our ability to intervene early is an intensely interesting area for us and on the area in which we focus. And then the other area, which is relevant to everyone in this country, is around behavioral health. The impact of behavioral health on disease, the need for more access to behavioral health for underserved populations, the need to digitalize that area so that it's readily accessible. It's 50% of at least claims-based telemedicine is devoted to behavioral health. There's a reason for that. It lends itself well to that format. And so those two areas are areas that we are, as we speak, developing, including microsites that we've developed for each of these. The diabetic one is active now so that a patient can start to do some self-navigation, if you will. They can go to that microsite, see what's available, and how to navigate to get access to that particular service. And we're doing the same thing for behavioral health. That will be released in the very near future. I'm talking months, not quarters.
Terrific. Well, it's been such a pleasure and an honor to speak with you, Dr. Gross. I know that you are helping to lead your organization into amazing new areas, and we're grateful for that.
Mark, I'm excited about the future, and the North Star here is how do we make healthcare equitable, accessible, and affordable for every single member of our society. And that's what we're working on. That is the guiding principle. Certainly we want it to be high quality. We have the resources now to do that. Our solutions are within reach. It's a matter of shifting the incentives and advocating where appropriate with government to shift the incentives towards value as quickly as possible. The most dangerous place to be is between incentives. When you're making your money on fee for service and trying to get to value, that is the most dangerous place because they work at odds to each other. And we've got to get out of that limbo and towards something that incentives that make sense for us as a society moving forward.
Right. The one foot in the boat problem that is constantly discussed. Exactly. Well, thank you again, Dr. Groves. This has been terrific. I've learned a lot. I know our audience has. So thank you very much for your time and your expertise.
My pleasure. Thank you, Mark.
Thank you. This concludes this session. Thank you to you and our audience for viewing. Have a great day.